Thank you everyone for coming this evening, on this October fall evening. My topic today is on colorectal cancer. My name is Dr. Bachelani. A little bit about me before we get started. I practice here exclusively at Monongahela Valley Hospital, board certified in general surgery. I'm also a member of the American Society of Breast Surgeons and a fellow of the American College of Surgeons. From Minnesota originally, and went to medical school at Creighton University in Omaha, Nebraska, and trained out here in Pittsburgh, downtown at Mercy Hospital. And I was in the military for a few years out in California, and about 3 years ago I returned back to this area and started practice here with Dr. Gonzalez and Dr. Crew. A little bit about the anatomy of the GI tract. So after we swallow food, it comes down the esophagus and then down into the stomach. And from the stomach, it goes into the small intestine. And the small intestine basically goes everywhere inside the abdominal cavity and then finally joins up with the large intestine. And the large intestine, it's also known as the colon, starts here, what's known as the cecum. And then this right colon or ascending colon then becomes a transverse colon, then the left colon, or the descending colon, the sigmoid, and then the rectum. So we monitor and we're concerned about the colon and colon cancer because cancers of the GI tract, the small intestine, very uncommon to have cancer. It's the large intestine or the colon where cancer is formed, and that's what we are talking about tonight. Once again, the anatomy that we just discussed. So colorectal cancer is very, very common. It's the third most common cancer in each gender and the second most common cancer overall. Lung cancer is the most common, and then for men it's prostate, and then women it's breast thereafter, and then colon cancer is third for each gender. And colorectal cancer, even though it's very common, it's very preventable. More than half of all colon cancers can be prevented with colonoscopies. So what is colon cancer? So colon cancer is a type of cancer that forms along the mucosa of the gastrointestinal tract of the colon. And along this inner lining of the large intestine, it starts by forming a growth of abnormal cells. A mutation, either passed down, hereditary, or spontaneous mutation, can start these inner lining cells to start growing abnormally. And then it grows into what's known as polyps. And then these polyps become larger, and then they become dysplastic, which is basically means precancerous. And then once these polyps have dysplastic cells, then the next step would be cancer itself. So one may ask, what are risk factors for colon cancer? A few of them here. Age. The older you get, the more likely it is to get colon cancer. Although recently we've been seeing a spike in younger patients getting colon cancer. And in fact, the colonoscopy screening guidelines just for routine, normal, average patient just recently changed from 50 to 45 with a lot of different societies. Diet, your diet can affect whether or not you're in high risk for colon cancer. Physical activity, the more active you are, this can help protect against colon cancer. Weight is another risk factor. Patients who are overweight may have a higher chance of forming colon cancer. Smoking and alcohol, both risk factors as well, and then diabetes. So colon cancer, very common, and how can it be prevented? Colonoscopy. So one may ask, what is a colonoscopy? Colonoscopy examination of the colon, also known as the large intestine, and we utilize a fiber endoscope. So this is an endoscope here, and it's a long tube. On this end of the tube is a light and a video camera, and that allows us to see and examine the colon directly, and we can biopsy different things using this colonoscope. We can even remove polyps, with a colonoscope. Colonoscopy is the same-day procedure. It uses conscious sedation, so anesthesia, would give IV sedation, kind of like a twilight zone, not completely asleep. And colonoscopies can take anywhere from 15 minutes all the way up to an hour. A lot of that depends on how difficult the colonoscopy is, how many polyps will need to be removed, and so forth. So colonoscopy, is both a diagnostic test and then it can detect cancer in polyps and potentially therapeutic in terms of it can biopsy and it can even remove some polyps. So screening, in general, we talked about colonoscopy as a utilization to screen for colon cancer. Screening basically means, taking normal, healthy patients who have otherwise no symptoms and doing a test on them to see if they have, a different disease before it becomes symptomatic, therefore trying to catch it early. Other examples of screening tests include mammograms for breast cancer, pap smears for cervical cancer, and then PSA tests, which is a lab test, or a prostate exam to detect prostate cancer. So the purpose of the screening colonoscopy is for the early detection of colon cancer. But in addition to that, it can detect and remove polyps before they progress into cancer. The early detection of cancer is important because the earlier you detect colon cancer, the more likely it is to be curable. So I talked about polyps, and there's different kinds of polyps. There's precancerous polyps, which means polyps that can turn into cancer down the road, and then non-precancerous polyps. The type of precancerous polyps are called adenomas. And the three different types, tubular adenoma, and tubular-villous adenoma, and then the villous adenoma. So as you go down the line, the villous adenoma is a higher risk polyp. Tubular adenoma is still a risk, but not quite the risk that villous adenoma has. And then finally, you might hear the term called hyperplastic polyps. And hyperplastic polyps, if you find them, they're not precancerous, so there's nothing to worry about. So once again, who should have a screening colonoscopy? Anyone over the age of 45 now should have a colonoscopy if the patient is asymptomatic and otherwise healthy. And then after that, every 10 years. Now, if we do find a polyp on a colonoscopy, we can increase the frequency, usually to every 5 years, but depending on the type of polyp, it can be even more frequently than that. Now, if a patient has a family member that has colon cancer or has otherwise symptoms like blood in the stools, then we may recommend colonoscopy sooner than that. So the different type of polyps, there's different types of adenomas, but there's also different shapes of polyps. One of them is a pedunculated polyp, and that's this polyp that forms on a little stalk. So it grows from a stalk and then forms a polyp. And it pops up and off of the mucosa there. Then we have a sessile polyp, and the sessile polyp is a flat polyp that forms along the lining of the large intestine. So as you can tell, a pedunculated polyp is a lot easier to remove with a colonoscopy. We can hook a snare around, lasso it there, and cut the polyp right there at the base and remove it entirely. A sessile polyp you can still remove, but it takes a little bit more work. Image of what a polypectomy looks like. Here we see a polyp forming on a stalk, kind of like a mushroom. And out of the colonoscopy, we come and bring the snare, lasso it around the polyp, bring it down, and then you close the snare down, close it down tight, and then you cut this polyp off. Now the polyp has been cut off, and this polyp we can actually remove and then send to pathology. So the pathologist can look at thin slices of the polyp under the microscope and be able to tell us what type of polyp it is, make sure there's no cancer within the polyp, and so forth. So cancer, is obviously usually much larger than a polyp, and you can see this big mass. And a couple things. Number one, it's too big to be removed with, just the colonoscopy. Number one, but number two, you would need surgery not just to remove this, but then to get adequate margins of intestine on either side, and then remove the lymph nodes as well, which which is why patients with cancer need usually colon resection. One of the other findings that we can see on colonoscopy is diverticulosis, and this is the diverticulum here. It's a little outflouching of the colon, and these can form as a low fiber diet. It's actually pretty common in the Western world, in the United States. About half of patients over the age of 50 form diverticulosis. By itself, diverticulosis is not a problem, but if you have diverticulosis, potentially down the line, it can form what's known as diverticulitis, which means when these things get infected, or these things can bleed. It's called diverticular bleeding. So there are alternatives to colonoscopy that you may have heard of. Fecal called blood test, the FIT test, which is a fecal immunochemical test, and then these, more recently we have the stool DNA test. And these are tests where, stool is sampled and sent off, and, we can detect whether there's blood in there or whether there's DNA of cancer cells in there. An advantage of these tests are it's less invasive. You don't need to go in to have sedation. You don't need to have a colonoscopy. But it's not as good as colonoscopy. It's less likely to find the polyps, that can turn into cancer. And, even if we do find, evidence of, colon cancer on these tests, then you would need a colonoscopy anyway. So these are alternatives if colonoscopy is, not tolerated or not preferable, but otherwise colonoscopy would be the, gold standard or better test to screen for colon cancer. With colonoscopy, we give patients these instructions. The day before, we have patients drink just clear liquids along with a prep. Usually go lightly. That's a gallon of special fluid. Helps clean out the colon, and the better the prep, the more likely we're going to be able to see all the mucosa and rule out any cancer or polyps. Patients usually arrive at the hospital, usually early in the morning, depending on what time the case is scheduled. And we can do the preoperative work, the procedure, and recovery, along with discharge, all within a few hours. But with a colonoscopy, even though you can go home the same day, you cannot drive home because of anesthesia. Patients cannot drive for 24 hours after the procedure. We have a program at Mon-Vale Hospital with myself and my partner, Dr. Gonzalez, where we can do colonoscopies without having to come into the office. Of course, if the patient is high risk or would like to speak to us prior to the colonoscopy anyway on a separate day, we're more than happy to see anybody in the office. But in terms of work schedules or whatnot, it's a quick and easy way to get the colonoscopy done because we can introduce ourselves, have the conversation the morning of the colonoscopy, and you can get the pre-op labs done and EKG done if needed that same morning, then have the colonoscopy done all in one day. Whereas, most of the time, it would be 3 days. One to meet us, another day to get the testing done, the EKG and the labs, just for the anesthesia purposes, and the colonoscopy itself. And then we have a script for the colon prep mailed to you, and it's done either by myself or my partner, Dr. Gonzalez. This is our office phone number. It will be in your folders. And our medical assistant, Charlene, can counsel over the phone. And after the counseling, if there's questions specifically you want before scheduling colonoscopy, we can always arrange for an office appointment as well. So a few points to remember and to wrap things up. With colon cancer, it's a preventable but common disease. And polyps and early stage colon cancers don't have symptoms, which is why it's important to have the screening done. And if you wait until you're symptomatic for colon cancer, sometimes it can be advanced cases, and sometimes even too late. So besides getting screening, eat healthy, stay active, and talk to your physician or your primary care doctor about getting screened for colon cancer, because screening can save lives. A little information about myself. our address for the office, which is in the Healthplex on 51, and our office phone number and our website. Thank you all for